So I just wanted to run over some of the background clinical data that we have for the patient-specific computer simulation. So the first component that we have with the computer simulation is called the finite element analysis. And this is basically where we create an aortic root model from the preoperative CT scan, and then we simulate the interaction with the transcatheter heart valve. And so Carl Schultz did the initial validation work in this in around 40 patients, which had post-operative CT scans. And as you can see from these results here, that the computer simulations were reliable at predicting the transcatheter heart valve deformation, so the minimum and maximum dimensions, as well as the displacement of calcium towards the coronaries. So once the finite element analysis is done, we then extract what's called the blood domain in order to perform computational fluid dynamics, which simulates paravalvular regurgitation. And Peter Dieger has done the validation on around 60 patients that were treated with core valve. And it demonstrated that the computer simulations are reliable at predicting moderate or severe paravalvular regurgitation as based on both angiographic and transthoracic echocardiographic criteria. And then the next component that's been added to the software more recently is the conduction disturbance modeling. So much as Hassan has been a pioneer in this area, we identify the membranous septum in 3 positions and then use that to identify where the left bundle branch is. And then we found that the pressure that's exerted by the transcatheter heart valve on this area, which is called the contact pressure, and the percentage of this area that is subject to pressure, that's called the contact pressure index, are both predictors for the development of major conduction disturbance, so either left bundle branch block or high degree AV block. And in fact, the combination of both of those 2 factors is highly predictive for conduction disturbance.
I have a comment on that. So there was a very good cadaveric study, a Japanese study, that looked at that, and they looked at there's a certain proportion of patients, around half, that have an intramuscular bundle, and then there's another quarter or so where the bundle passes just below the vertex of the muscular septum, and then there's a portion that also have what's called the naked bundle, where the bundle actually passes somewhere within. So this, as Cameron said, is an imaging surrogate. It does not tell us exactly where the bundle passes.
Okay, thank you.
So the work that we've been working on is that using the computer simulation bicuspid, as we strongly believe that this technology has a role in these more complex anatomies. And so here you can see the process that's involved. So we take the preoperative CT scan, we use that to create a finite element model of the aortic root, and then we perform what's called finite element analysis to simulate the interaction between the transcatheter heart valve and this native anatomy. And here you can see the deformation of the transcatheter heart valve within the bicuspid anatomy. And then we extract the blood domain to perform computational fluid dynamics to simulate paravalvular regurgitation. And this has been retrospectively validated in around 40 patients that had postoperative CT scans, and both ourselves and Jorn Brouwer has also done some retrospective validation. And we can see that the computer simulations are reliable at predicting the transcatheter heart valve deformation and the development of paravalvular regurgitation. And having validated this technology, we've described our usage in our first 9 clinical cases that we had. Out of these cases, 3 patients were predicted to have moderate or severe paravalvular regurgitation, and these patients were referred for consideration for surgery. And in the remaining 6 patients, we used the computer simulations to optimize the transcatheter heart valve sizing, as well as the position of implant. And as you may be aware, in bicuspid anatomy, there is a lot of discussion on how we size these and what sort of different sizing strategies we use. And we certainly found that using the computer simulation was a very helpful adjunct to sizing. Since these first 9 patients, we've gone ahead in the last 12 months to treat an additional 10 patients with the computer simulations. And here you can see that the results of the computer simulations here. And as you can see, the models quite accurately reflect the leaflet configuration and calcium distribution of all these different types of bicuspid morphologies. All of these 10 patients had favorable clinical outcomes, including 2 patients that were treated surgically. Now, an interesting thing that we've been working on in the last 12 months is that we know that the computer simulations are reliable at predicting paravalvular regurgitation. But the question is, and we know that paravalvular regurgitation is associated with long-term outcomes. So the logical sequence would be, well, can the computer simulations predict which patients are going to have a poor outcome long-term after TAVI? And I think this is a quite important consideration as we move into these younger patient cohorts. And as we can see here, if the computer simulation predicts that you're going to have a poor outcome after TAVI, that is, you're going to have moderate or severe paravalvular regurgitation, you have a much higher chance of developing paravalvular regurgitation. But also at long-term follow-up here of 2 years, your hazard ratio for death is 3.5, so highly significant. So I think as we move into these younger patient cohorts, we should certainly be considering that our high-risk patients be considered, or sorry, high anatomical risk patients be considered for computer simulation to help guide whether they should have TAVI or surgery. And finally, the TAVI guide study has been recently presented by Nahid Al-Fakir, and obviously was involved in this project, which was looking at the role of the computer simulation in 42 patients to see what the adjunctive role was. And what we found was that in around 38% of patients, it changed the procedural strategy. And that wasn't done by a change in valve size. These were all tricuspid patients, so only 1 patient had their valve size changed, but rather it was through a change in implantation depth, either to minimize conduction disturbance or to minimize paravalvular regurgitation. So that's sort of a summary of the data that we have to date. We've got a lot of more interesting projects coming through at the moment, including conduction disturbance with newer generation devices, potential projects looking at pure aortic regurgitation, and Nicholas Van Meegen is running the Precise TAVI registry, which is looking at the role of technology in complex anatomy, so heavily calcified valves and bicuspid.